Hello, I'm Dr. Robert Lelouch, a board-certified OBGYN physician with over 30 years of clinical practice. Today we're going to talk about breech presentation and external version. So you may know that breech presentation is when the baby's bottom is down instead of head down. So the head's not in the pelvis. Depending on when that happens, it's not a problem at all. So babies early on change positions all the time, but we really start focusing in on the baby's position around 36 weeks. And so generally, I check my patients, and if I'm not convinced on exam, it's called Leopold exam, then that's when I do a little portable sonogram to verify that. If the baby is in the breech position, then we offer external version, and that is a process where we literally push on your belly and turn the baby. And the reason is that it's safer to have a vaginal delivery than a C-section, and the risks of an external version are low. And it turns out having a breech vaginal delivery is higher risk. Used to be done more commonly, but a C-section turns out to be safer than a breech vaginal delivery. The biggest risk being that the baby can get stuck because the body is smaller than the head. We don't often do breech vaginal deliveries, and that's why we offer the external version. So what is the success of an external version? The success rate varies quite dramatically depending on many risk factors. So it can be, depending on the studies, 50, 60, 70% success rate, and all the way down to 30% success rate. So what are some of the variables? It's where is the placenta? Is it above the baby or below the baby? If it's above the baby, it's a little harder to feel the baby and get to the baby. Also, the location of the baby's spine. Also, how much fluid there is. If there's a lot of fluid, the baby moves easier. If there's very little fluid, it doesn't really move. If the bag water is broken, then you really can't turn the baby. Depends on the mom's weight. It depends on the mom's size. It depends on you as a mom, your ability to relax and be able to, because we push on your belly and you've got to be able to relax and not tighten up your muscles. There are many factors there. For many years, the external version was performed without any anesthesia, so no epidural. The thought process is we didn't want to push too hard. We wanted to make sure that you were comfortable and able to tolerate. However, recent studies say that it is okay to do that in the right selected patients with no major problems. There is the potential for the baby not tolerating the procedure or for some problems. They're low risk, less than 1%, but because there is a risk and we're actively intervening, we want you to be prepared at a facility where we can move towards an emergency C-section if the baby doesn't tolerate the procedure. I have done 500 to 1,000 of these procedures and never had to do that, but the risks are quoted under 1%. But a baby having a cord problem, bleeding problem, an abruption, the placenta separating, the baby just not having a reassuring fetal heart tracing, not being able to tolerate and resulting in a C-section. And that's why generally we tend to plan for the external version around 37 weeks or 37 to 38. After that, it still can be done. However, the success rate starts to fall because it is dependent on how big the baby is, and the baby can be growing half a pound a week at that stage. My experience is also women who had many children, sometimes their uterus is more relaxed, they can have some more fluid, and they can be women who show up late in the pregnancy with it breech, and often are successful. After 40 weeks though, I have had very limited success and almost never try to do that procedure unless there's a good risk assessment to attempt it. So Very safe, easy procedure. One thing to remember is you're in control for the procedure, okay? So that means if it's too uncomfortable, you just say stop, and we have you stop. You do have to avoid talking during the procedure because that tightens your muscle. So we want you to talk, we engage you, we talk to you. I generally put a little mineral oil on your belly to help things help move, and our hands slip over your belly easily. And we use an ultrasound to look how the baby is doing, and we monitor you afterwards for a couple hours to make sure the baby did well. So it's actually an exciting procedure, especially when it works out well. It doesn't always work the first try. Sometimes we try one direction, sometimes we try another. And again, it's an interactive, how are you doing? We tried one way, it didn't work that way. We talk it over with you. So if you're facing an external version, know that it is a safe procedure, that you definitely need an evaluation by a capable physician who's done the procedure, knows what they're doing in an appropriate facility. It can reduce your chance of needing a C-section quite dramatically. There is a small chance, and I have seen it, turning a baby, and then you're successful, come on back, turns backwards again. So small chance of that. If it does happen, we wait till you're a little further along, and then we offer turning it, and then as soon as the baby's turned, break your bag water and put you in the labor. That would be approximately 39 weeks, but there are too many variables to give you exact numbers and dates because all of this has to be tailored to your personal situation, which I don't know. For example, if you have high blood pressure pregnancy, you're not really a good candidate. If you have other problems, health problems, or the baby has issues, not really a candidate. So this is give you an overview, some general education to allow you to ask questions and be better informed when you're speaking with your own physician who'll be performing this procedure. I hope you found this helpful, and we appreciate your feedback. Thank you.